and welcome to our Echo session today on navigating psychedelic journeys, a comprehensive webinar on psilocybin therapy and end-of-life experience. Before we get into our presentation, I would like to take the opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original people in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. Briefly, a little bit about the ECHO project. The Palliative Care ECHO project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. Please feel free to stay connected and check out our website at echopalliative.com. The Palliative Care ECHO project is supported by a financial contribution from Health Canada. Therefore, the views expressed here today do not necessarily represent the views of Health Canada. Many of you know Pallium Canada for our LEAP content, our LEAP courses. Predominantly LEAP Core, which is one of our most popular courses, is an interprofessional course that focuses on the essential competencies to provide a palliative care approach. It is ideal for any healthcare professional who provides care for patients with life-threatening and progressive life-limiting illnesses, and it is accredited by the CFPC and the Royal College. If you'd like to learn more about LEAP Core or any of our other LEAP programs, we invite you to check out our website. I will now hand it over to our host, Dr. Jose Pereira, to take it from here.
Thank you, Diana, and hi everyone and welcome. So I'm Jose Pereira and I'm the scientific advisor for Pallium Canada and the co-founder. We were founded already 24 years ago in the year 2000. I'm professor in the Division of Palliative Care in the Department of Family Medicine at McMaster University and professor in the Faculty of Medicine at the University of Navarra, Spain, where I'm now. And coming to you from Spain. We've got a fantastic group of presenters and panelists today, and I'm going to ask them to present themselves. So, David, who will be first up, could you present yourself, please? Introduce yourself.
Hi, good morning, good afternoon, everybody. David Clements. I'm the Executive Director for Psychedelics Research at Queen's University, where I hold a number of other senior administrative responsibilities, but I'm speaking to you from Ottawa on the unceded territory of the Anishinaabe Algonquin Nation.
Thank you. And then over to Claudio Soares.
Good morning, everyone. Good afternoon. Claudio here. Claudio Soares. I'm a professor of psychiatry at Queen's University. Also the regional lead for mental health and addictions for Ontario Health and chair the psychedelics advisory committee at Queen's. Very happy to be here with you this morning.
Thank you. And so David and Claudia will be doing the presentations, and then we'll have a backup team with our panelists. And our panelists today are Dr. Kylea, Dr. Lyle Galloway, and I'm not so sure if Geneviève has joined us yet, but she may join us, Geneviève Lalumière. I'll ask Kylea to introduce herself, please, and then over to Lyle.
Hi, good afternoon. Kylea Potvin, medical oncologist in London, Ontario. Very pleased to enjoy this panel with everyone and look forward to engaging some really good discussion.
Excellent. Thank you. Lyle.
Hi, Lyle Galloway. I'm a palliative care physician in Calgary. I run the pain and palliative consult team at the Tom Baker Cancer Center here and co-lead for the Alberta Palliative Tumor Group, as they call it in Alberta. Geneviève had another meeting, but she's going to sign in by phone shortly, I believe.
Perfect. Thank you. So just very quickly, Pallium Canada is a non-profit organization with the mission of building primary level palliative capacity across the country. So the vision is that all healthcare professionals across the country and other care providers will have core palliative care competencies to provide a palliative care approach to patients with serious illnesses, and we try and initiate palliative care much earlier in the illness trajectory than only in the last days or weeks of life. Pallium Canada has been partially funded through a contribution by Health Canada. In fact, the ECHO series is funded by Health Canada, as we heard earlier. Pallium can also generate some funds to support operations and research and further development through course registration fees and sales of the Pallium pocketbook. In terms of other conflicts of interest, so as scientific advisor, I do receive honoraria from Pallium Canada. David Clements has declared that the Psychedelics Research Collaborative at Queen's has received donations from a number of private and philanthropic and professional associations since its launch in 2021. And Claudio Soares declares that he has served as a consultant for Otsuka, Bayer, SI, and Diamond Therapeutics and received grants from the Ontario Brain Institute and the CIHR. So again, welcome, and just a few reminders, some housekeeping notes. Please, if you wish, you can introduce yourselves through the chat. I see there are a lot of people online, which is fantastic, so we might not be able to get through all those introductions. In terms of comments, if you've got comments or questions to ask the presenters and the panelists, please do so using the Q&A function. That's much easier for us to monitor that one than the chat. So please use Q&A for comments and for questions. We are recording this session, and the recording and the slide deck and the links will be emailed to all registrants within a week of this webinar. However, the session will also be available for asynchronous watching and learning on the ECHO website, the Pallium ECHO website after the session. Please do remember not to disclose any personal health information during the session if we're discussing about cases. So with that, I'd like to hand over then to David Clements. David, over to you. Thank you very much.
Thank you. And two things I'll just say by way of a brief orientation. The first is I just wanted to extend my thanks to all of the participants on the call. Having lost 2 family members in the last 5 years to cancer and having had both of those individuals benefit from the dedication of palliative care providers, just wanted to extend my thanks. The second is I suspect there will be a number of detailed questions. I see one already in the chat with respect to specific technical information related to psychedelics. Any questions we're unable to answer on this call today, we are happy to follow up with answers for you. Our colleague Ron Shore, who took part in the previous webinar, is an expert in this area, has reviewed every clinical trial. And so rather than wing some of these answers, we may refer some of those and get back to the participants. So that to say, just to provide a brief introduction, because I think one of the big eye-openers for me in the last 3 years has been the degree to which some of my assumptions as someone who has done some work in this field over the years, some of the things that have been eye-opening to me. So the first is to just clarify, psychedelics are still illegal in Canada. I get a lot of requests from family doctors and others that are simply looking to make requests or to access these substances. And this may be stating the obvious for many of you, but they are illegal. They are scheduled either under Schedule 1 or Schedule 3 of the Controlled Drugs and Substances Act in Canada. Psychedelic mushrooms, psilocybin, for instance, under Schedule 3, MDMA, which we'll talk a little bit today, under Schedule 1. So those are subject to everything, including mandatory minimum sentences in Canada. And as many of you know, there are drugs that have medical purposes in Canada that are still scheduled. Ketamine is sometimes considered a psychedelic, although not by everybody. That is both a drug scheduled under the CDSA, as well as something that is available in Canada. I want to just note that this has been an area of rapidly escalating demand from patients. You may have seen this in your practices and in your work. But we have looked at an absolutely massive increase in questions and demand from patients. Some of that, and there is a bit of a synergistic relationship here in between the growth of the market in Canada. We saw a rapid spike in 2020 and 2021 in the number of new companies operating in the psychedelic space, up to about 200 companies at one point in 2021, 2022. Many of those are working in the areas of extraction of these substances or producing GMP certified substances. There are many more companies that have been in the space of establishing things like retreat centers, or in fact, what has been probably the most lucrative for the line of business for those companies is to provide training. So you may be confused when you see out there many, many requests or offering of courses to take training, to be certified, and so on. Sometimes this is equated with there's been a case of legalization in this case. There in fact hasn't. In most cases, officially, people are being trained for the purposes of being practitioners or therapists in clinical trials. But in many other cases, this is done in an anticipatory way to future changes that may come down the road. One other thing I want to note is that we have seen a rapid increase in research. I'll show a brief slide momentarily, and Claudio will talk even more about this. And so we're in an interesting situation, which we've seen previously with cannabis, for example, where research has really lagged the public and policymaker and provider interests. So we're catching up, which is awkward because it does create some challenges for scientists to feel that there is pressure to produce research along timelines that are expected by those various decision makers. There are concerns historically that doesn't produce the best kind of science. But that to say, many scientists are scrambling at this stage, which is what we're seeing in terms of the steep growth in the number of trials. I do want to note that these are substances that are not without risk. Now, many folks would argue, because we have had broad use in the population of many of these substances, folks would argue, you know what? We can just observe that we don't see massive increases in emergency department admission data, for instance. We can conclude that these are safe for everyone. We can't conclude these are safe for everyone. We do know that people have negative experiences. We do know that in some cases, people have negative experiences that are profound for them, and that in many cases, they will also report are beneficial that are associated with using psychedelics. But we do know that there is a substantial rate, roughly 10 to 15% of people that report negative experiences, even with what are seen to be quote unquote safe drugs like psilocybin. The last thing I just want to say by way of intro is that the landscape for you is going to change very rapidly in the next few years, as indeed it already has. So you will see this term psychedelic renaissance used frequently. And I just want to clarify what we're talking about when we say renaissance. I won't go into this slide, you can read it to yourself, but suffice to say, we have traditional religious use going back many, many thousands of years, probably. And we have archaeological data that supports that, particularly in South America. We did see, as many of you know, significant growth in research in the 1940s to 1970s, including here in Canada in provinces like Saskatchewan. One of the members of our scientific advisory committee, Erica Dick, is the foremost expert in Canada here about some of those experiments. Pursued in many cases a different treatment model, shall we say, in many cases with drugs like LSD. These were involved to actually, were used to promote a kind of existential crisis for many patients as a way of actually, in the case of reducing use of alcohol, promoting a very negative experience that would then deter future use. With the advent of international treaties in 1971, we saw Canada conform to many other countries in the scheduling these drugs that I referred to earlier. We see drugs, of course, added many times over time to that schedule. We sometimes see drugs removed, although not that often. I can speak to cannabis, which many of you know in real time here in Canada. And in some cases, we have drugs that are psychedelics that are indeed not scheduled. So 5-MeO-DMT, also known as toad venom, you may have read about, is in fact not scheduled, so could be considered legal in Canada, although is not necessarily encouraged for use. We saw some pretty significant changes both globally in terms of a regrowth in interest in psychedelics, much of that led by centers like Imperial College in London and certainly Johns Hopkins University in the US. Many new clinical trials taking place in the context of prohibition. And then many of you may have seen Michael Pollan's book released a few years ago, How to Change Your Mind, which really led to an explosion in interest in, shall we say, the mainstream. In Canada, we saw a growth of the use of a provision called Section 56(1), which allows application for the use of controlled substances. Many times that's in the case of research. Many times it's in the case of, for instance, the use of supervised consumption sites for supervised opioid use. Those provisions were also used for access to psychedelics, mainly in the palliative care setting, up until 2021, at which point we have seen no new use of that particular provision under the CDSA. And what we've seen in the last 2 years is the use of the what's called the Special Access Program through the Therapeutic Products Directorate, which is a very different kind of program, generally used as a way of accessing drugs in emergency situations where we have a drug that has been approved in another country whose regulatory system is analogous to Canada's. We have seen Health Canada say explicitly that's where they would like to see applications that are not related to the conduct of a clinical trial, that we want to see physicians providing patient history, evidence of the drug that might help them, and then there are exemptions issued on a one-by-one basis. So I've gone into the weeds a little bit here, but it's really just to clarify that we do not have legalization in Canada. We do have avenues of access. Palliative care has certainly been at the leading edge here. This is a picture of Thomas Hartle, who is a patient in Saskatchewan. He's currently leading a challenge under Section 7 of the Charter of Rights and Freedoms as a patient who he has a terminal cancer. And he has repeatedly used psychedelics in controlled settings with therapists previously provided through that Section 56(1) exemption. Many of these patients have now gone and said, in fact, they would like that mechanism to be used, and that the inability to use that provision actually interferes with their rights under Section 7 of the Charter. So that is certainly a space to watch for many folks who are wondering what the implications in the future will be for clinical use of psychedelics. So this is my last slide. If we're looking ahead and anticipating as palliative care providers, what are we looking at happening in the next couple of years? I think there are a few things that certainly are not guaranteed, but that are likely scenarios. The first of those is that it is quite likely there will be a sort of risk-managed approval of MDMA by the FDA in the US, perhaps later this year. This is in response to 2 large clinical trials related to the use of MDMA-assisted therapy for post-traumatic stress disorder, and what seems to be, due to a number of signals from the FDA, an openness to approving MDMA in that setting. That doesn't mean that there are immediate implications for Canada. What it certainly means is that the providers in this case will look to other jurisdictions, and Canada is likely to be high on that list, to make similar applications for medical approval. So again, this won't change the scheduling of the drug. This does not legalize the drug. What it does is it means that US officials, Canadian officials, European officials will then need to look at, can this be provided and what's included on the label? They will not say in which setting this needs to be provided, by who should be involved, what is the team, what is the setting. Those are all what we would call practice of medicine or practice of healthcare issues. So they will be looking to the regulatory bodies in that case to say, okay, you're the medical experts here, you're the nursing experts, you're the experts of other allied health professions. What does this look like? What should this look like? In one province in Alberta, we've actually seen the province get out ahead of this last year and actually say, if we ever get to a point where this is the case in Canada, it will be psychiatrists who are doing this in hospitals. Okay, so they've preemptively done that. Other provinces will look at this on a one-by-one basis. We will certainly see negative experiences, such as the ones I mentioned earlier. Can't say this is without risk, as indeed no drug is without risk. So that will certainly be a concern from a risk management perspective for the providers. It will be a concern for clinicians, and it may be a concern for patients. How do we know? Do we have appropriate screening criteria in place? How are we going to deal with certainly minimizing these things and providing appropriate follow-up care for those individuals? But this is really going to challenge our providers, and certainly it is going to challenge government officials when we look at what type of situation we will need in place to be able to effectively manage a situation like this. So that's how I'll turn it over to my colleague Claudio to speak from the clinician and scientific perspectives.
Thank you so much, David. It was a nice way to segue for us to talk about a little bit of the clinical trials of mental health. But before I jump into that, I just want to make a comment on the reason why I think it's for me it's really appealing to be talking to all you today. So my work as a clinician, as a psychiatrist, is in what we call consultation liaison psychiatry. So I see patients in medical and surgical floors, and I do a day a week in oncology and palliative medicine. So I see firsthand and very closely the existing gaps in supporting our patients with mental health issues, psychological issues, depression, anxiety, demoralization, existential distress. So it is really a pleasure to be sharing with you some of the what we know, what we don't know about psychedelics in this field. So I'm going to take on some of the things that David was mentioning before, and just really highlight some of the history of the psychedelics to the point that we are now. So as mentioned by David before, psychedelics really went through a dark phase in the 70s and is experiencing what we call now a renaissance interest. And part of that is driven by the work that was being done over probably the last 20 to 25 years. And it was catalyzed probably by the interest in ketamine, which is an interesting phenomenon because ketamine is really not a true psychedelic agent per se. It's not a drug that will induce altered states of consciousness the same way that we have, for instance, with MDMA or psilocybin, but it has probably triggered that interest in drugs that have a dissociative effect and maybe a mechanism by which some that were more skeptical to drugs such as ketamine realized that the drug could have an effect per se, but also be very an interesting companion to psychotherapy. And we're going to have a discussion on, are those drugs really being effective alone, or they're assisting psychotherapy in that process. So just moving here very quickly to this slide is really, sorry, let's go one back for you. So which slide is really highlighting some of the things that David mentioned before. So we are almost going back to the future. So psychedelics were really very popular in the 50s and 60s. And at that point in time, they were really supporting psychotherapy processes. But then in the 70s, with the so-called war on drugs, they became extremely stigmatized and rescheduled or scheduled as substance one, which is basically questioning if there's any therapeutic use and highlighting the high potential for abuse. And then the mainstream clinical research was definitely stalled for decades into, as I mentioned before, in the early 2000s when we started seeing an re-emergency of clinical trials and research on psychedelics. And part of that, as we mentioned before, was because of the interest in ketamine as an agent for depression. And this is just a slide that illustrated, what we call the psychedelic winter, when we have very little, if any, research happening in psychedelics. And you can see that the numbers of research papers really exploded in the past 15 to 20 years, and was preceded by the use of ketamine as anesthetic, but also the start using of ketamine as an antidepressant agent as well. And that is somehow, I would say, followed by the current FDA landscape. This is from a current seminar, a very recent seminar that was promoted by the FDA, looking at some of the clinical challenges or logistical challenges to bring psychedelics from the underground to the mainstream, and looking at how those agents are being now studied and there are actually applications for them to be used clinically. And you can see there was really nothing happening in the early 2000s until 2014, 15. Then you start seeing ramp up in numbers of applications per year, to the point that in the last couple of years, psychedelics were actually close to 15, 16% of all applications for new use by the FDA, which is remarkable if you see. That's including everything: cardiology, diabetes, hypertension, anything that could be being applied for new indication for the FDA. It just shows you the degree of interest that is being shown by pharmaceutical companies and other regulatory bodies looking for permission or granting permission from the FDA for clinical use. A lot of what you're going to hear on psychedelics, the psychedelics are different, is related to what we call set and setting. And I thought that maybe we should spend a few minutes defining what set and setting is. If you're taking a medication for hypertension, diabetes, really doesn't make any difference if you're taking on your car, on driving to work, or if you're taking in the morning, we're having a breakfast in your backyard with a beautiful scene, or if you're actually taking on the go when you stop by Tim Hortons or Starbucks and you have some time to take that pill. It's really not affecting the efficacy of the pill or your expectations of how the medication will work. This is not the case in psychedelics, which is also one of the challenges for us to generalize or extrapolate some of the findings from psychedelics, both from the psychedelic use in the underground or no medical use or religious rituals or use in the general population versus psychedelic being used in clinical settings. So when we talk about set and setting, the set refers to really the mindset of the study participant, of the patient. So think about the attitudes and expectations and intentions that each participant has when they are coming to use psychedelics. And that includes their personal beliefs, their hopes, their fears, and some of the personality traits that might make them more susceptible or more vulnerable to experience the psychedelic effects. And all of that is not only important to the use of psychedelics itself, but also the role of preparation sessions. And we're going to dive into what entices into the preparation sessions as well. But that's also true for everybody who's involved. So that's also true for the therapists. So the therapists will also come to psychedelic use with their own personal beliefs, hopes, fears, and their personality traits. And that combination, that interaction, relationship between the patient and the provider or the participant of the clinical trial and the researcher has been shown to be significantly impactful on the outcome of psychedelics. So that is somehow unique compared to other areas of research. I would say not unheard of, but unique in a way that will limit our ability to really predict the effect size and generalize the results of clinical trials to the general population that might be experiencing psychedelic use in a very different setting or set. So the setting itself is the space in which you're going to be providing psychedelics. It's the physical space, the location, the room, and the studies have shown that different furniture, noise level, lighting, audio-visual equipments, all the resources and environment that is created for the use of psychedelics have a very significant impact on how patients experience the psychedelics, but also how that experience might be perceived as safe, pleasant, as opposed to potentially threatening or harmful. And that we probably learn a lot from years and years of use in no-medical settings, in religious rituals, when the community rally behind or around an individual who's using psychedelic for therapeutic purposes. And there is really a care provided by the community, and sometimes by the elderlies or the shamans, that really helping that individual to have the experience in psychedelics to be as safe and as comforting as possible. So how we translate that into a medical setting is one of the challenges that we're all going to have when psychedelics, or if psychedelics become more widely available. So as I mentioned before, so many cultures have used psychedelics for religious and ceremonial healing reasons. And they have done that primarily in outdoor settings with a group involvement. And sometimes there is really the experience with interconnectedness with the nature and their communities. And that process really doesn't stop there, continue to grow And what we call the integration phase involves many individuals from the community, which is very different what's happening in the medical setting, when it's happening in an office or in a research space, very sterile, very medical-like, so to speak, with not a lot of involvement from the community or other members that will follow that individual after the experience with psychedelics. So different settings for different purpose. This slide just is illustrating what happens in a more experimental, recreational psychedelic use or use in the nature versus here on the right-hand side is really clinical trials when you have two therapists providing support to an individual who's here using MDMA, and then you have a control environment, which looks a little bit like an office or maybe a living room, providing the patient with some comfort during the experience of psychedelics. So I mentioned a little bit before to dive into what constitutes a psychotherapy session for psychedelics. And it probably can be divided in three different buckets. One bucket is the preparatory sessions. Then the second one is the dosing or drug treatment sessions. And then that we call the integration or integrative psychotherapy. So prep sessions, dosing sessions, and integration sessions. In the prep sessions, and you can see probably in different clinical trials, they may vary between 2 to 3 prep sessions. They're really focused on preparing the individual to what is yet to come from their experience with psychedelics, but primarily to prepare, it's actually bi-directional, it's preparing the individual to what is coming in terms of the experience with psychedelics, but also providing the therapist with the information of what are the expectations, what is the mindset of the individual who's coming for psychotherapy with psychedelics. So what are their beliefs, their experience, their previous experience with psychedelics, what are their goals, their objectives, what they're looking for, what they're looking forward to experience with the use of psychedelics. That will also help to build that relationship of trust between the individual who will be guiding the patient during the psychedelic experience and the patient or the study participant. The drug dosing session may vary depending on the psychedelic that's being used. For instance, psilocybin will have a peak of activity, physiological activity in the first hour or two, but the psychogenic effects might last up to 6 hours, between 6 and 7. So individuals will remain in the room with 2 therapists for 8 hours. So you can imagine that the preparation for that session and the setting for that session has to be really well prepared for that individual to have an experience and for the therapist and for the environment to be as comfortable and as safe as possible. So we want to reduce also any psychological reactions. We want to prepare the individual for any physiological changes they might experience, but also reassure them that you're there to provide a safe space for that experience. And they might be able to rely on you, for instance, with some safety touch or therapeutic comforts if needed, within boundaries that are very clearly established between the therapist and the patient. And then you have integrative sessions or integration periods when between 2 or 3 sessions, they will have a chance to revisit the experience with psychedelics that they had with the therapist and revisit the thoughts and feelings that only emerged during the session, but what came in the days or weeks afterwards. And that process is probably very different to what happens in the general community. That process will last for weeks and sometimes months when people are using psychedelics in a non-traditional way. They have the support of their family in the community, whereas in the medical setting or clinical trials, it really is limited to a few sessions and probably a few follow-up sessions as well. So it's one of the challenges for us to extrapolate what we know from years and years of use in the underground space versus integration clinical trials. So that's probably one of the areas that we need to advance in knowledge to be able to know what's going to happen to individuals exposed to psychedelics in the long run. So we could probably spend hours talking about the many different factors that can influence the experience of psychedelics. So I decided just to show you this slide to just highlight how how complicated, how complex it's going to be for us to really understand truly the effects of psychedelics and how they're going to be affecting practice when and if they become available. So it comes from the expectations that I mentioned before, the mindset of the individuals thinking about using psychedelics, how they are selected to come to clinical trials. It's probably a selection bias. People who actually agree to participate in clinical trials of psychedelics are probably a little bit different than most patients who agree to be on the study on, antidepressants or opioid medications for pain relief. There's also previous experiences and expectations that they might have from using psychedelics in a recreational environment versus a medical environment. Their personality traits, their ages, their personality that might make them more susceptible to, out of ordinary or altered states of consciousness, and be able to express that in a verbal way or through drawing or music. So there are also characteristics of individuals who might be more prone to experience psychedelic experience in a positive way. And then there is the expectations or biases from the therapists and the way they're going to be using psychotherapy attached to psychedelics, whether you're using more manualized and standardized psychotherapy to provide individuals with more support versus being more guiders and guide the experience in a less intrusive or less structured way. And then there are questions about drug dosing and the acute response and how much of that will alter the integration phase, whether we are actually using the right placebo drugs in clinical trials. As you can imagine, it's very hard to keep blinding on psychedelic studies without causing some sort of a altered states of mind. So we have been trying clinical trials, different ways to keep the studies blind, but I can tell you that this is one of the major challenges in clinical trials with psychedelics. So I hope I'll give you a sense of how complex that field is still. And just as my last slide is just showing some of the additional challenges for psychedelic research now. The research ethics boards at hospitals just learning how to do those studies. And you can imagine the challenges that we have to overcome in terms of safety and storage of those drugs, making people feel comfortable to providing them, the right informed consent form for caregivers. We have to involve caregivers. We have to be with the study participants for 24 hours after using psychedelics. Some of those questions remind me of the challenges that we have in early stages of studies with genetics or imaging, when we are kind of a brave new world and trying to figure out what was ethical, what was the right thing to do. But there are some things that are unique to psychedelics, and I think the stigma around those agents and the pressure from the community to make that access quicker. It is also, I will say, researchers are really balancing that pressure between providing care to individuals who are in need and they're not responding to conventional treatments, while really at the same time assessing the safety, the efficacy of those agents. So stop here, and I'll be happy to answer any questions you may have.
Fantastic. Thanks very much, Claudio and David. I see there's some interesting questions in the Q&A. Some of them Claudio and Kylea have already answered, but I think I'd like to bring them back again and highlight them so that everyone can see them. But before we do that, I was wondering if any of our panelists, so Kylea, Lyle, Genevieve, do you have any questions for David or Claudio, or comments to add to what they said?
Thank you, Jose. Not at the moment. Thank you.
Yeah, I don't want to start, making comments, because I think it'd be nice to allow questions from the attendees to come through, but maybe to both of our panelists, our main presenters. It's the issue around how these are, how regulation's going to come around this, and I am a big believer in that we need to have, thoughtful, I'm going to say thoughtful as opposed to careful, because those are, I think, two different things. But there was already a mention already about, in one of our provinces, it's, psychiatrists that are doing this. And, so I open it to our two presenters to give their thoughts on, what does this look like from a thoughtful and practical sense? Because I'm a medical oncologist and I've been doing lots of training in this and gathering teams. What do you see as, if you could put together the ideal team for how we deliver, these medicines and therapies, what would that look like?
David, you want to go first?
Sure. I mean, I'll just to touch on where the question is coming from. I mean, I think certainly, first of all, our regulators, the government officials that are going to be responsible for approvals are going to be very challenged. I think currently, and there is sort of, again, we're talking about drugs that are now being used for clinical indications, but drugs that have been used for recreational or religious purposes for a long, long, long time, right? So we have a sort of fervent base of supporters who very logically will be saying, this is totally safe. We should do what we've done with cannabis, with many of these other drugs, because the risk is very low, and it's certainly much lower than other things that are currently available. And I can understand where that comes from. It doesn't change the decision-making process of folks in government whose authorities are constrained by regulations that have been developed in response to legislation passed by elected officials. And so they may very well agree with many of those statements, but would say, I don't have the power or authority to do that. So it wasn't your question, but just by way of an intro, I think it's important to clarify that. What does the team look like? I mean, and again, certainly this is the subject of very passionate debate. And many of those folks I just referred to will say, I don't want to be provocative, but they'll say, well, this is the anti-psychiatry, right? This is better than psychiatry, and we don't want psychiatrists anywhere near any of this. And in fact, medicalizing this model will defeat much of the value of how these substances are, how these medicines are administered and used. And I think many of us can understand where that comes from, right? The less inflammatory response would be to say, we need an interprofessional approach here, very clearly. We do need folks that understand how the brain works in these cases to know, and we need basic expertise as it pertains to dosage and so on. But it would be a real shame if we overlooked much of what folks that have been doing this, underground, illegally, at significant personal risk to themselves, to completely overlook the knowledge that those folks bring here would be a huge loss, I think. So finding a way by which we can preserve, what's been learned, however that's been learned, to do it in a respectful way, particular to, Indigenous healers and some of the folks that have much of that tradition and history is really important. But I think we also need to practice evidence-based medicine.
So I was just going to add a few things to what David mentioned. I think this is going to be very molecule-based and molecule-driven and even dosing-driven. I don't see, for instance, a pathway for something like ayahuasca to become legalized to be used as a psychedelic in the therapeutic setting. It's very, ayahuasca, it's a very intense psychedelic experience that relies a lot on the space and the setting and the community rallying around you. And I can see many regulatory hurdles to bring that into the medical setting. At the same time, you might have psychedelics such as psilocybin being approved to be used without psychotherapy if they're shown to be effective, as they have shown to be effective in single doses for depression with minimal psychotherapy supportive, or even microdosing, which is still in the early stages of using. The purists will probably have a seizure, listen to what I'm saying now, because they believe that the medicine itself is a curative agent, and we're just there as bystanders, right? So this is the psychopharmacology approach to psychedelics, not really the classic integrative approach to psychedelics. But it could be that low dose microdosing gets approved with very little, if any, regulation beyond or besides what we have for antidepressants in general. But the psychotherapeutic use of psychedelics such as MDMA and psilocybin, I think would be a targeted approval. In US, likely MDMA will have a specific sites or centers that would be approved to have trained therapists, and at least one of them will have a medical training or nursing training for physiological or medical emergencies. And I see FDA presentation suggesting that that would be the case, but as David mentioned, that would be regulated by provincial or state bodies, and probably differences between countries as well. But I think that would be different depending on what agent you're using, what dosing you're using, and what purpose you're using for.
Thank you. Claudio, what you mentioned the microdosing, and I see there's a question in the Q&A about the microdosing, and you did say a few words about that, but I don't know if you wish to elaborate further on that. The question was from one of the participants. Could you comment on the use of
microdosing, the idea of microdosing is taking advantage of the psychopharmacological properties of those agents without necessarily touching to alter states of consciousness. So as you probably know, psilocybin, for instance, has a very clear activity in 5-HT2A receptors, similar to antidepressants or anxiolytics. And studies have shown that they can reduce ruminations or ruminative thoughts or process, like we see in patients with OCD or anxiety or generalized anxiety disorder. They tend to ruminate about or be preoccupied and worry about things. There have been a few studies. Just one second.
For 3 room A. For 3 room A.
Sorry about that. So they have shown to have some anxiolytic and antidepressant properties in clinical trials, but most of them were open trials or surveys. So they have yet to be tested in phase 2 or phase 3 clinical trials. They also being used for pain management and reduction of symptoms, behavioral and psychological symptoms of dementia or BPSD, Parkinson's, migraine. So there are quite a few neuropsychiatric, neurological conditions that are trying to use lower doses of psilocybin. The more classic or mainstream use of psychedelics will tell you that the believers will tell you that you need to have altered states of consciousness to benefit from those agents. So the microdosing or lower doses would not be effective because they are not really open the doors to change your perceptions or values or beliefs of your traumatic experiences or your depression, anxiety. So you need that, and you need that neuroplasticity that is caused or triggered by higher doses of psychedelics to have the therapeutic effect. I think those two schools of thoughts will probably coexist for a while. Most of the research is on higher doses, but there is some emerging field interested in microdoses as well.
Thank you. Kylea? Are you muted, Kylea?
I didn't get to see Lyle's answer. I think he was answering this on the panel, but just for the sake of, I think, a lot of people on here as well, because the question was also, the person was mentioning that they're seeing a lot of people coming to them doing their own microdosing. And, you know, this is where, you know, I am actually just a really big believer. You know, I'm a physician and a medical doctor, and I love neuroscience. I'm a neuroscience geek, and I really believe in, you know, trying to understand the science so that we can do these things better. But, you know, also just like that, the relationship, the setting, and especially how we handle integration, I think is really, really important. And, you know, how doses play into that, you know, hard to know at this point. And I think the thing with microdosing is for people understanding, you know, guiding people by understanding some of the neuroscience, like how these drugs affect the receptors, how long they occupy them, you know, because there's the need for how people microdose is really important in terms of the receptor occupancy and the effect. If people are microdosing and they decide they want to do a full psychedelic dose, that could certainly have impact on what kind of experience they have with that. I think we still have to be very mindful of drug-drug interactions, even at low doses with this. And the other thing is using microdosing in some people, depending how they do it, can actually increase anxiety in some people. So I don't think it's as easy or straightforward, and it will be interesting to see more studies coming out. People are doing it, but I think if, at least in terms of guidance, if you can learn everything you can about sort of how the receptors are occupied and understanding that why there needs to be a break, you can't take it every day, doing good drug-drug interactions or reaching out to a pharmacist or a physician that can help if you're not a medical person, but have people doing that. I think if people are doing this, how can we safely and effectively help them do that? I think there's a lot we need to understand to do this well. So those are just some of the cautions that I do bring out. So if people are coming to you, maybe if you have a physician you can work with that knows a bit about this, that can help guide them so that they're not getting more anxiety and they're getting some benefit. I think those are some of the things that I would mention about the microdosing, given all the unknowns that we have about it. Because again, microdosing is some of what is being used as the placebo arm on clinical trials because it does have an effect. And even, people's diets, other medications, the acidity of their stomach can be affecting what kind of dose they're actually getting. So we need a bit of all of it. And that's why my question about the teams, right? Anyway, that was just a comment on microdosing. I don't, Lyle, if you wanted to comment, I didn't get to see your answer. Sorry about that.
No, that's good. I think I was just saying there is a lot of unknowns. I think probably the placebo response is significant where people are accessing microdosing, and yeah, the other thing would be there's no actual legal supplier of microdose products, so it's easy to access, and people are no doubt accessing microdoses online. I guess the question is, what are you actually getting, and what microdose are you taking? The doses with microdosing are generally so much lower than what we would typically think of as a psychedelic or macrodose. That the risks of interactions and so on are much lower. The person who asked the question identified themselves as a therapist, and that would be my main recommendation, I think, for somebody who is experimenting with microdosing, would be that they're in contact with a therapist on an ongoing basis to support any changes that are happening.
Yeah, if I could just jump in very quickly here. It reminds me a little bit of the discussions where you all face with some of our patients or clients when they come to you and they say, I'm using this combination of the CBD and THC that I found in that particular supplier, and that's really helping with my anxiety. And then you look at them and say, I have no evidence to even have a discussion with you because I don't know what is really in the product they're using, what is the real concentration, what is the how reliable it is that one batch is exactly like the other one, and who's prescribing, so to speak, and what symptoms you're targeting, what is the placebo effect. So it is unfortunately a little bit of a wild west in the way that is the microdosing is perceived as safe or safer, almost as a entry door to psychedelics. I don't think we can shy away from that conversation. I think the more we know a little bit of the pharmacology and the effects of that and the risks of drug-drug interaction, but I think we are miles away from having the answers for people who are looking for a safer way of using psychedelics as a microdosing.
Claudio, thank you. I'm just wondering, going to one of the questions, someone asked that one of the presenters or panelists mentioned that about 10 or 15% of patients have a very bad experience. Could you perhaps, or someone else, Lyle, Claudio, and then Lyle, speak a little bit about that negative experiences, just describe what those could look like?
I can jump in and yeah, I'm sure Kylea, you probably have some thoughts as well. These are often, well, so we're talking about a bad trip, I guess, in colloquial language. when you're talking with psychedelically educated folks, often these will be referred to more as challenging experiences. So not necessarily a negative experience, but challenging. And what can that look like? It can be all over the map. So this could be bringing up unconscious things that people have not dealt with. Definitely anxiety can be a big part of it. Paranoia can be part of it. Projection of subconscious things onto the therapists or the setting can be a big thing. And generally, yeah, it's important to support people through that. And again, the integration process afterward, you can't downplay the importance of that. Many people who have challenging experiences will, in retrospect, say, that was absolutely terrible. I never want to do that again, but I'm really glad I went through that and I learned a lot from it. So it's not that these are negative experiences that have negative outcomes. They can be challenging experiences and may actually open the door for positive outcomes and positive change with the right integration approach.
Thanks, Lyle. I see Laurie Abbott posted pre-existing anxiety may be exacerbated by use. I see our time's soon coming to an end, but there is another question here, which is any evidence around the psilocybin as an anti-inflammatory, having an anti-inflammatory effect, and that is on the inflammation, the cytokines, and in the context of cachexia. Any thoughts?
So I can't comment in great detail on that, but I can certainly say it's correct that there is literature to suggest that. Without getting into a long discussion around trial design, etc., I think there are always challenges when it comes to individual studies in this space, particularly due to the small number of patients that are often included. But yes, that has certainly been something that has been noted in the last couple of years. The other thing I would just say is there was some comments with respect to eating disorders. We do see a number of registered trials now, both in Canada and in the United States, looking at eating disorders specifically.
Great, thank you. Well, we're up. The session has come to an end. I really want to thank our presenters and panelists. So David and Claudio, thank you very much. Lyle, Kylea, thank you. And Genevieve, thank you very much for being part of this and adding in your experiences. To all the participants, thank you for joining us today. And please do provide an evaluation of the session that helps and informs us on how we develop these sessions going into the future. So thanks again to all of you. Thanks for joining and thanks for the generosity of sharing your time and insights with us. Thank you.